Welcome to PharmaDocs with your host, myself, Dr. Jay Reznick, and Dr. John Roberson. Practicing oral surgeons bring you the latest and greatest in pharmacology as it affects you in your daily dental practice. All right, here we are. Hey, John, how you doing?
Jay, great. How are you today?
All right.
Awesome.
Good. We have a busy day today, don't we?
Look,
we got a lot of drugs to cover.
Jay, it will never change. I mean, pharmacology is always going to be busy. Okay.
Mm-hmm. Yeah.
We're always going to have information to talk about and to help our fellow colleagues who are in the trenches like we are every day. Jay,
Yeah.
You know that?
Mm-hmm.
All right. I mean, that's important. Okay. You want to learn from your colleagues who are doing the same thing that you're doing every single day, Monday through Friday.
Yeah. Seeing those actual patients day in and day out.
That's right. I mean, today, Jay, for example, I mean, the majority of my patients were on 5 medications or more.
Mm-hmm.
And to our audience out there, when we talk about 5 medications or more, you can go ahead and dub that polypharmacy.
Yeah, for sure. Did you see that study basically saying that cannabis users require much more anesthesia and pain medication?
And I think that's something we've known forever.
Yeah.
Okay.
And now it's in the literature. Yeah.
Now it's in the literature. That's correct.
Yeah. Not just anecdotal.
No.
So
that's
good.
right.
All right. So
like you said, busy show. Let's get going. We got a lot to talk about for our group out there.
That's not what we want. We want that button. Okay.
Excellent.
Very good. Okay. So we're going to start off today just kind of reviewing things about risk factors. John mentioned about polypharmacy. Patients who are on multiple medications. And of course, as our patients get older and have more medical problems, medical advances to keep them alive longer, you're going to see patients on more medications.
Absolutely. I mean, everything we've pointed out right here, Jay, I mean, patient risk factors equals increased medication use.
Yeah.
And, Jay, we're starting to see more and more of our colleagues taking sedation training, as well as more advanced dental implant courses as well. You're going to have to know your pharmacology. You're going to have to know medical emergency preparedness. You're going to have to know sedation emergency preparedness as well. You got to stay up to date.
Yeah, absolutely. Yeah. So again, patient risk factors for all the medications we use will more risk factors they have, the more medications they're going to be on, the more we need to know about drug interactions and effects of these drugs on our treatment.
That's correct. All
right. So let's move on to our first drug, Luncimio, which is mosunetuzumab. Wait.
Well, it's a UMAB. Okay.
It's a UMAB. Exactly.
That's right.
So it's a monoclonal antibody. And so this is a drug that is actually a first-in-class drug that was developed to treat either recurrent or refractory follicular lymphoma, which is probably the most common type of slow-growing non-Hodgkin's lymphoma.
Right. Jay, the thing about you just said there, first in class, we did a lot of that last year as well. I mean, we're looking at major advancements, Jay, in pharmacology and the medications coming out right here. I mean, more and more first in class. We just talked about one last year with Alzheimer's. We got another one coming up here as well too. But I didn't want to get off that subject, but first in class, how exciting that we're living in these times right now.
Yeah, and it works both on B cells and T cells. So what it does is it targets the CD20 receptor on the B cell and the CD3 on the T cells. And what it does is it directs the T cells to basically engage and eliminate the cancerous B cells. So it is a novel medication, first in its class.
Yep.
One of the side effects of it, though, that's pretty significant is it can cause a big release of cytokines. And
CRS.
Yeah, so that can have, one effect that it has is it could suppress the activity of cytochrome P450, our old friend in the liver. And so it can increase the blood levels of drugs that we may be prescribing to our patients, like codeine, ondansetron, we get for nausea, oxycodone, tramadol. So we have to be aware that any drug that we give that's metabolized in the liver by cytochrome P450, it's going to elevate the blood level. So we got to be careful in our dosing with patients who are on this drug.
And Jay, I said CRS, and we'll say a lot of acronyms on the show, and I want the audience out there that's cytokine release syndrome.
Yeah,
also referred to as cytokine storm.
Yeah, exactly. And this can have all kinds of effects on the patient: chills, hypotension, irregular heartbeat, breathing problems, headache, dizziness, nausea.
Right.
And so it can be pretty severe. It's actually fairly common with this drug, and it can get so bad that it's actually life-threatening. So,
and Jay, the thing about it too with CRS, that can also happen, my friend, with these autoimmune diseases in patients that we see as well too, like psoriatic arthritis, rheumatoid arthritis, Crohn's, ulcerative colitis, myasthenia gravis, Sjogren's, lupus. So a lot of these disease states can also be affected by CRS as well too.
Yeah. Yeah. So we have to be aware of those things. Now, there are other drugs that are used also for follicular cell B-cell lymphoma, and those are Gazyva, rituximab, which is probably one of the most common ones, or also known as Rituxan, and Ruxience is actually a biosimilar of Rituxan. And so again, we're looking at this name, all these names, and we mentioned about this being a monoclonal antibody. So I just want to remind everybody of the naming protocol for all these drugs. So basically, the first part of the drug is random, made up by the drug company. The second part is what the target is of the drug, and the third part, before the UMAB or before the MAB, is what species the antibody was developed in. So if we go back and look at Luciminio monotuzumab, it's got too many syllables. We see that the TU prefix after the mosun means that it's directed against a tumor.
Correct.
And the Zumab means that it is comes from humanized, which means it's part human and part non-human. So generally, the antigen part is the human part, and the non-working is usually from some other species of animal. So you're gonna come across this a lot with these naming protocols, because we're getting more and more of these drugs.
And Jay, like we said, first of all, if they're on a UMAB, what have we said over and over in the past? These patients are going to be on antibiotics after we get through treating them.
Yeah, they're definitely immunocompromised. We have to be careful. We have to treat them as if they're going to develop an infection with whatever we do. So we want to be sure to cover them with antibiotics prophylactically.
Okay.
Even if it was a procedure that we wouldn't normally cover someone for, just because of their higher risk.
That's right.
Okay. So the next drug is Sulenca. And this is, as you can tell from the name, lenacapavir, that it is an antiviral. And so what this is a drug that's used in combination with other retrovirals for the treatment of HIV, specifically HIV-1 infection.
Right.
And as you can see here, it's used in the treatment of heavily treatment-experienced people with multi-drug resistance. So that essentially means this is someone who's been on these HIV antivirals for quite a while, and they've developed resistance to these medications. And so what this drug does, it's in a new class of drugs known as capsid inhibitors. And what it does is it inhibits the capsid in the HIV virus. And by disrupting the capsid, which is what contains the nuclear material and the enzymes for replication, it basically kind of stops the virus in its tracks.
Okay.
And the other thing we have to know is that these drugs are, or drugs that are strong or moderate inducers of cytochrome P3A, like erythromycin, clarithromycin, will decrease the plasma concentrations of this drug. So we got to be careful when we have patients who are on Sunleca that we treat them with other antibiotics. Now, if they're on these medications, we also have to be aware of some other interactions, because lenacapavir by itself is actually a moderate inhibitor of cytochrome P3A. And so with drugs like narcotics, like fentanyl or oxycodone or hydrocodone, it will increase the level of these drugs in the bloodstream, which could lead to respiratory depression, which could lead to respiratory failure and even be fatal. So we've got to adjust our doses of these type of drugs. It also does the same thing for tramadol and for benzodiazepines. And so we have to be aware of that. And if we're going to put the patient on any corticosteroids, like we may give them a Medrol dose pack, it will increase the blood level of those drugs, of steroids. So it increases their risk of getting other type of infections, but also can lead to Cushing's syndrome and adrenal suppression.
Well, and Jay, that's a great point you bring up, because, we got the term, the substrate, the inhibitors, and the inducers.
Yeah.
And as you were saying, with the inhibitors of CYP3A4, okay, that's a very important enzymatic enzyme. That's the number one in our body right there. If you have an inhibitor of that, therefore it doesn't metabolize the medication. So therefore you have an increase in the drug in your body.
Exactly.
Whereas if we have the inducer, it induces a stronger enzymatic activity. Therefore, we have less drug in our body. So, for example, what's the big deal about grapefruit juice, Jay? So, I mean, everybody says, don't drink grapefruit juice. Well, big fancy word here. The agent that causes the problem with the grape juice effect is furanocoumarins. Okay. All right. And it's a very potent inhibitor of CYP3A4.
And 450.
And I want to tell everybody out there, we're going to do a show just on enzymes, so everybody can get very familiar with this as well, too, because like Jay just said, there's certain drugs you give that may increase the drugs infected in our body or decrease that drug.
Right. Exactly.
And that now, guess what? You just caused an adverse drug reaction.
Right.
Okay.
Because you didn't check the interaction between these drugs.
That's right.
So you got to check it now for everything. Now, the nice thing about some of the electronic medical records is they will cross-check, you put in the medications the patient's on, and if you prescribe something that has a reaction, it will tell you, it'll give you a warning to make sure that you're going to either go through with this prescription or maybe change to something else.
That's right. And Jay, the thing about with grapefruit juice, if you know that you're writing one of these medications, then you know that your patient likes grapefruit juice. If you don't, ask them, say, look, could you leave it alone for 24 hours before I prescribe this medication? Stay off of it while you're on this medication that I prescribed, and then wait another 24 hours after you finish my prescription, then enjoy your grapefruit juice.
Yeah.
All it takes, Jay, is one whole grapefruit or 200 milliliters of grapefruit juice.
Yeah.
And you can have an unkind effect on the medications that these patients are taking.
Yeah. Yeah. And if they're on some of these medications, they shouldn't chronically, they shouldn't be eating grapefruit or drinking grapefruit juice at all.
That's right. That's right. And so, like I said, we'll spend an entire show and probably even some other things in the future on the enzyme systems.
Yep.
Because they're important to know, because there's 5 major ones you need to know about.
Yeah. Yep. And they can get you in trouble if you don't.
That's right.
All right. Our next drug is Nexobrid or anacauslase Oh, wait a minute. We're out of order. Sorry.
Yeah, well,
I'm looking at my notes. So, anacosulate, so Nexobrid, and what this is basically a powder that's in a gel vehicle, and it's a biological that's derived from bromelain. And what it does is it has proteolytic enzymes that will actually break up a burn eschar. So, for patients that have these heavy, aggregations of necrotic burn skin, and it only works with thermal burns. This is very effective. And again, it's a new product that will help remove these burn scars or remove this dead tissue. And so generally what they do is they apply it, they leave it for about 4 hours, and then they scrape what they can off and then apply it again. So generally 2 applications about 4 hours apart, and it's very effective in removing the necrotic tissue in a burn scar.
Okay.
All right. So the next one then is Briumvi. Ubletuximab.
I like that. Again, another MAB.
Yeah, another MAB.
Okay.
Yeah. So this being a Zymab, that means it is a chimeric. So it comes from a couple different species, non-human, that are used to derive this. And it's interesting that it's tuximab, which generally means it's directed against a tumor, but this is actually directed or used for treating relapsing forms of multiple sclerosis.
Right.
Yeah.
And what did we just say about 2 drugs before? This is multiple sclerosis is an autoimmune disease as well too.
Mm-hmm. Yeah. And so what it does is it acts on the again on CD20. It's a CD20 monoclonal antibody that works to slow the progression in relapsing multiple sclerosis by depleting the immune B cells. And so, of course, the whole pathophysiology of MS is that it's an autoimmune disease where these antibodies that are generated from the B cells are causing destruction or actually causing demyelination of nerves, and that's what leads to the symptoms.
That's right. And now, okay, what are some of the common issues we got to worry about with Briumvi? Infections.
Yeah.
And what was very startling to find out more about this drug is that upper respiratory tract infections are one of the more common side effects of Briumvi. Okay. So you just heard me say in the very beginning of our show, more and more people are starting to do sedation in their office. And guess what is a contraindication to sedation in your office?
Yeah.
An upper respiratory tract infection.
Exactly. And there are 3 different types of multiple sclerosis. Usually the first diagnosis is what's known as the clinically isolated syndrome. So it's basically the first episode of neurological changes, and it could be something as subtle as a little blurred vision. It could be diplopia. It can be tingling in the arms or legs, upper lower extremity. But it generally lasts less than 24 hours. And goes back to completely normal. That's sort of a precursor of the chronic relapsing remitting form of the disease that is what most patients will then progress to. And that's where you get times of remitting disease or relapsing disease where they have the symptoms and then it remits. It basically gets better for a while. And this is seen more frequently, about 70% of the time in women, or actually 2 to 3 times in women, so about 66% higher. And generally, the first sign is in patients who are between the ages of 20 and 40. So generally, you don't see MS coming on in teenagers, and you don't see it in older adults, although, there are exceptions always to every rule. These are just kind of the average ages of onset.
That's right.
Yep. Okay. So next drug is lecanemab. And so this is a drug that is just been released, just been approved for treating Alzheimer's disease. And so we can look at the name lecanemab, and the NE before the MAB means it is or actually the N means it's directed against the nervous system, and the E tells us that this monoclonal antibody comes from hamsters.
Yes.
Yep. So
and so again, okay. So Jay, last year we had the drug aducanumab, also known as Aduhelm.
Yeah.
Okay. Remember that one had some scrutiny about being approved so quickly with the FDA, but again, it was a first-in-class drug because this is the very first. Right now, all we had before, Jay, was just medications to treat the symptoms.
Right.
Of Alzheimer's.
And this was to treat the cause or the etiology.
This is going after the amyloid that is seen in the substantia nigra located in the brain.
Yeah, these beta amyloid plaques.
That's right. It builds up. That's correct.
So one of the issues with Aduhelm, A, it was $56,000 a year for treatment. B, the patient's copay was $11,000 out of that. And it was really questionable. It definitely reduced the beta amyloid plaques from forming, but they weren't really seeing, they couldn't really tell if it was actually effective in slowing progression of the disease. And that's the same thing actually with Leqembi. It went through the kind of an accelerated protocol to get it on the market. And again, it also shows reduction in development of these amyloid bodies, but it's not clear yet if it actually slows progression of the disease. So even though it's in this accelerated pathway, it's still, it has not been shown to be clinically effective in actually treating and slowing the progression of Alzheimer's. And it's only about $26,000 per year. So it's a little less expensive, although Aduhelm, after all the hubbub about it being $56,000 a year, reduced its price to cut it in half.
But it is exciting, Jay, to see these two drugs out right now within a 6-month period. Okay, what's coming next? Okay,
exactly.
And whatever it is, we're going to let you know as soon as possible through PharmaDocs.
Yeah, and I think we mentioned with Aduhelm when we talked about it last year, as well as Leqembi, that one of the known side effects that has to be monitored for is either bleeding into the brain or swelling in the brain, and it can be very minor and completely asymptomatic, or the patient can become symptomatic and have headaches, dizziness, confusion, visual changes, nausea, difficulty walking, and even seizures. So before patients are started on either of these drugs, they usually get a baseline MRI, and then again after about 6 months of treatment to see if either the bleeding or swelling in the brain has developed. Because if it has, they don't want to wait until it becomes symptomatic. They're going to get them off of the drug and go to something else.
And CJ, what you're talking about is that ARIA, that amyloid related imaging abnormalities.
Right.
That's what they're checking for right there as well.
Yeah.
Too. But,
so it's you see these changes on MRI, on imaging, before you actually see clinical symptoms.
That's right. Okay.
All right.
Great stuff.
All right. Next on our list is, and I love this name, AIRSUPRA. It's super duper.
Great. Yeah. Great name. Great name. Treatment for asthma. So Jay, we finally got another rescue inhaler, but it's much better than just albuterol. Right.
Because in addition to having the beta agonist, which is albuterol, it also has a corticosteroid. So this drug can be used not only as a rescue inhaler, but can actually be used for chronic management. So the patient can be on, have one drug for both. They don't have to have multiple inhalers or multiple medications. So, with the beta agonist, what they do is they relax the smooth muscle in the airway and open up the airway so the patient can breathe better. And what the steroid component does is it reduces the inflammation. So it reduces the likelihood of them getting an asthmatic attack. But if they do get an attack, then it's used as basically for treating acute symptoms.
And I want to remind everybody, when we talk about medical emergency preparedness, we always talk about a medical emergency. Albuterol is one of those emergency drugs you must have in your emergency drug kit. That is the primary drug for an asthmatic attack.
Yeah.
And make sure you have this medication.
Yeah. And again, this medication will interact with strong cytochrome 3A4 inhibitors, which includes erythromycin, clarithromycin, that we may prescribe for our patients. So we want to stay away from these drugs if the patient is using AIRSUPRA, and because it'll increase the blood levels. And in fact, and corticosteroids will have the opposite effect. They'll actually induce rather than inhibit cytochrome P3A, and lead to a reduction because it'll increase metabolism of this drug.
So coming to an emergency drug kit near you will be AIRSUPRA.
Yeah.
All right.
Probably not too far in the future.
That's right. Because the dosage is 12 hours apart. Mm-hmm. I mean, how nice, give 2 puffs and then you're good to go. All right?
Yeah, exactly. It's a longer lasting drug than some of the inhaled steroids that are being used now.
That's right.
Okay. So we'll move from asthma to treating schizophrenia and bipolar disorder. And this is RYKINDO. And you'll notice the name risperidone is very familiar. You're like, well, hasn't this been around for a while? Risperidone, isn't that risperidone? I've seen this on my patient's medical history that they're using these drugs. Well, the difference between risperidone and RYKINDO has to do with how it is basically the vehicle that it's in. So with the tablet and oral form, risperidone, this has to be dosed 1 or 2 times per day. So you have to worry about the patient being compliant with their medication by taking it once or twice a day. And again, one of the things with some of these things like schizophrenia, especially, or bipolar, is patients stop taking their medications because they don't like the way that it makes them feel. The risperidone, or the RYKINDO rather, is in basically a microsphere technology. So it's a timed release over 2 weeks. So the dose is 1 IM injection every 2 weeks.
And Jay, when you bring that up, I couldn't help but think about a separate disease state that we're seeing the same thing on these weekly or bi-weekly injections, that being diabetes.
Yeah, exactly.
About how much more compliant our patients are going to be and how much better they're going to be with their A1Cs.
Yeah.
But yeah, this is great that you're getting this long-acting injection right there as well for bipolar disorder.
Yeah. And for bipolar disorder, it can also be used in conjunction with like lithium and kind of other standard medications. We also, again, drug interactions. If it can interact with clarithromycin, ciprofloxacin, ondansetron, which we all prescribe and cause irregular heart rhythms. Narcotics, fentanyl, morphine, codeine, hydrocodone, in conjunction with risperidone can increase the CNS depression. And drugs like ketamine and benzodiazepines can also cause CNS depression, leading to drowsiness, confusion, difficulty concentrating, increased sedation, and even respiratory depression. So again, we've got to check our interactions with all these new drugs, because many of them interact with medications that we use daily in dentistry.
That's right.
Okay, so let's move on to the next one, Brenzavvy. And this is a treatment for type 2 diabetes, along with diet and exercise.
And look, again, it's an SGLT2 inhibitor. All right. And we talked about this last month as well, too. There were several drugs released for diabetes as well. Yeah. And, Jay, we talked about the off-label use on some of these SGLT inhibitors for a
sodium glucose co-transporter. So that sounds like it works in the kidneys and the nephrons, and that's actually where it works.
Yes.
And what it does is it increases the urinary excretion of glucose. So the patient will excrete more glucose in the urine, which will lower their glucose level. They also will have obviously increased urinary output. So one of the side effects could be dehydration or ketoacidosis. So we have to be real careful that we don't give them any medications that can interfere with this function, or especially cytochrome P450 inhibitors. And some of the other SGLT2 inhibitors that we've talked about before, like Jardiance, Invokana, and Farxiga.
Okay.
Right. Okay. All right. Let's move on to our next one. Orserdu. So this is a treatment for breast cancer, specifically ER positive, HER2 negative. So what that means is it is estrogen receptor positive and human epidermal growth factor receptor 2 negative. And so what this means is it's estrogen receptor positive, but HER2 negative. And what the HER2 is basically a protein that controls cell growth. And so if the breast cancer is HER2 negative, then it tends to grow slower and it's easier to treat as long as it's ER positive. So it has those estrogen receptors that can be blocked by this medication.
And that goes along with that ERS1 mutation as well, too, because when you do have an ER positive cancer, it will respond to endocrine or hormone therapy, but after a while it can stop working.
Exactly. It'll stop producing. Yeah.
Right? So it'll become resistant to that endocrine therapy, Jay.
Yeah. And what Orserdu does is it actually binds to the estrogen receptor, the ones that don't work properly, and results in a downregulation of the estrogen receptor. So it reduces the number of estrogen receptors and also blocks them from functioning. So it's in a class of selective estrogen receptor downregulators, otherwise known as SERD medications, SERD medications.
And then Jay, we got to be worried about drug interactions also. Besides just someone with breast cancer, again, this is going to be another one of those scenarios, Jay, where we're talking about antibiotics for our patients.
Yeah,
we got to cover
because it's modified by the cytochrome P3A4 system.
Right. So people taking Orserdu can be affected by the inducers as well as the inhibitors.
Right.
And again, the inducers will induce enzymatic activity, therefore decreasing the drug response in the body. Okay.
Exactly. Yeah.
And then the other one, the inhibitor, is just the opposite. It decreases the clearance. Therefore, you wound up with a higher dose of that medication.
Exactly. Which we don't want either.
No,
we don't want that either.
And one of the inhibitors is like ketoconazole or itraconazole.
Yeah.
If that's what you prescribe for fungal infections, but
we don't prescribe them all that often. Just basically the antifungals, the ketoconazoles and nitroimidazole antifungals.
But Jay, us being dental healthcare professionals, many of our patients are on herbal supplements. Okay. All right. So you might notice someone's is taking St. John's wort or maybe even golden seal. Okay.
Yeah.
So St. John's wort is a powerful inducer. Golden seal is a powerful inhibitor.
Yeah.
All right. And you might say, hey, look, your medication is not going to be regulated correctly. You need to talk to your physician or your oncologist about that as well, too.
Yeah. And, if you haven't done it already, it's a very good idea to, on your intake form, your medical history form, that you ask specifically about herbal as well as, holistic and over-the-counter medication.
Yeah.
Because patients are taking more and more of those. It's a multi-billion-dollar industry.
Oh, absolutely. And Jay, we'll definitely do a show just on that as well, too.
Yeah. Yeah. And all these drugs can affect other drugs. Like, a good example is the G drugs like ginger, ginseng,
Ginkgo
biloba can increase the level of warfarin in the patient's blood and cause increased bleeding beyond what they're being anticoagulated. It'll raise their PT. All right, so we'll move on to our last drug of the day for Pharma Friday of Jaypirca, which is pirtobrutinib. So this is, again, you see the inhib, it's an inhibitor of usually an immune process. And so this is used to treat a different kind of non-Hodgkin's lymphoma, the mantle cell lymphoma, which is where you get the cancer cells forming on the mantle layer or the outside layer of the lymph nodes. And this is one of the rare forms. And it's also used when the drug when the cancer is refractory to other drugs. And so the way it works is it's in a class of medications known as the Bruton tyrosine kinase inhibitors, BTK inhibitors. And so these work by basically binding to Bruton kinase, which is a receptor that's found on a lot of B-cell leukemias and lymphomas. And what these drugs do is it inhibits the activity of BTK kinase. But a lot of times patients, again, will become resistant to these medications. And one of the differences between Jaypirca and some of the other BTK kinase inhibitors is those are known as covalent irreversible binders. And so after a while, they will start to be less effective, whereas Jaypirca is a non-covalent reversible BTK inhibitor that binds differently to a different site on the receptor and can treat patients that are not responding to the other BTK inhibitors that they may be on.
And Jay, the thing about what this is used for is the MCL, mantle cell lymphoma.
Right.
And that's a very rare blood cancer and a form of non-Hodgkin's lymphoma.
Mm-hmm. Yeah.
And it arises in the B lymphocytes, which is a type of blood cell in our immune system. And then it's located in the mantle zone of the outer edge of the lymph nodes.
Right. As opposed to the follicular zone that we talked about with, let's see, our first drug, which was not Sulenka. Lunsumio, which also treats B-cell lymphoma, but it's the more common form, the follicular carcinoma, as opposed to this mantle layer B-cell carcinoma.
And see, as that spreads further off of the mantle cell, it can also get in the bone marrow, the spleen, the liver, or the digestive tract. Okay.
Yeah.
So
much more aggressive.
This drug also went through the FDA accelerated approval program as well, too, because they needed something out there for MCL, and it got approved rather aggressively and quickly.
Yeah. So they're still doing randomized control studies to see, they know that it can inhibit BTK kinase in resistant patients, but the question is, does this actually have an effect on the progression of the disease? And so the answer to that is in the works.
And here we go again, Jay. What other drugs will affect Jaypirca?
The cytochrome P3A inhibitors like clarithromycin. And
we do write that drug. Okay, that is written by dentists. Okay, so that's a strong inhibitor.
Or zithromycin. See, we got, the Z-Pak. So we ought to be careful. Again, that we know that clarithromycin is a cytochrome P3A inhibitor. and to use caution or don't even use clarithromycin or azithromycin or erythromycin if we can avoid it. Now, the inducers, as you mentioned, St. John's wort, dilantin, drugs that we're not really going to be prescribed. And then there's some moderate inducers. Again, they're going to be phenobarbital or pentobarbital, phenobarbital, which are going to be drugs that we're not really going to prescribe.
That's right.
Yeah. Okay. So I guess we've gotten through all of our drugs. We zipped right through those. So now we're going to move on to our medical emergency of the month.
Are you going to come up with some type of echo right there? Like I like how you said that right there.
Yeah, I'll have to see if I can do that. I don't know. I'll have to check.
Okay. All right. So we haven't told our audience what medical emergency this is.
That's right.
And you know, Jay, for a while there, for about the last year and a half or so, I was on the lecture circuit pretty seriously. Mm-hmm. All right. Had very good crowds. Mm-hmm. I show a video, and that video basically outlined what you have in that slide right there. A sudden loss of consciousness, no pulse, no breathing.
What could that be?
Well, Jay, I hate to say it, my audiences did not know what it was.
Yeah. Mm-hmm.
And you know, there's a lot of medical emergencies that we've got to know, and some of them have to be treated rather quickly, or you may have a dead patient in your office.
Yeah, exactly. So this is not a myocardial infarction, which is a plumbing problem, basically ischemia to the heart muscle. This is due to an electrical problem where the patient basically goes into AFib generally.
Sudden cardiac arrest.
Exactly.
So, and again, Jay has not seen my lectures, but that's exactly right. As soon as I show sudden cardiac arrest, I talk about the plumbing problem and the electrical problem.
Yeah.
The myocardial infarction versus the sudden cardiac arrest.
Yeah. Let me make that a little bigger so everyone can see it.
Yes. The chest pain versus myocardial infarction versus cardiac arrest versus sudden cardiac arrest. They're all different.
Yeah, where the patient's down, pulseless, not breathing.
So again, if somebody drops right in front of you or just goes limp in your chair and you have no breathing, no pulse, you should automatically be thinking sudden cardiac arrest. It's one of 3 medical emergencies in your office that you've got to treat in about 3 minutes or less, or you have a dead patient.
Yeah. And you need to call 911 as soon as you realize the patient doesn't have a pulse and isn't breathing. Because you got to get EMS there as quickly as possible.
Jay, I'm going to say this until I stop saying it. Call 911 in the very beginning because it will take time for them to get there.
Yeah.
Go ahead and get the wheels of life rolling to your office, and make sure your front office personnel knows how to do this, and make sure you have a backup system to make sure you say, hey, we did call 911, right? Oh no, I didn't know if I was supposed to call or not. Yes, you were supposed to call. Yeah.
You want to make sure that you have an emergency plan for your office. So if something happens, everybody has a defined role. So there's no confusion. You know, one person will be designated to call 911. Someone else would be designated to assist with BLS. Someone will be in charge of going to get the AED. And so everybody knows their role. So the first thing you're going to do after you've called 911 and started your emergency plan, you're going to make sure the patient is supine on their back. And you want to put a CPR board behind them. Okay. That's hard. That's firm, because a dental chair is not very firm. And you also want to elevate their legs, because what that does is it basically moves blood from the extremities into the central circulation, into the patient's core, the heart and brain, which is where you need it to be. So once you've assessed the ABCs, their airway, breathing, and circulation, and you've started BLS, so you're going to start chest compressions and rescue breathing, 911's already been called. You are going to start basic life support right away. I mean, this should happen within 15 seconds of the patient going down. And you should have the defibrillator there.
Why are we doing chest compressions? Because we're trying to move the oxygenated blood that still remains in this person's body to help circulate through the system so that we do not have an anoxic brain injury as well, too.
Yeah, brain or cardiac. We don't want to have ischemia of the heart also.
That's correct.
We want to try to keep the heart viable for as long as possible.
And the question is, Jay, do you know where your AED is right now as we're telling you about this medical emergency? Where is it located in your office? Yeah. Are your batteries in date?
Yeah.
Are your pads in date? Do you have pediatric pads?
Yeah.
You do not want to have a sudden cardiac arrest in your office and your batteries are expired or your pads are expired and a negative outcome occurs to this patient.
It's got to be checked every month, and everybody in your office needs to know where the AED is stored and be able to get to it very easily. Shouldn't be at the back of a cupboard.
I mean, Jay, we're talking about 350,000 deaths a year. 90% of the people outside of a hospital having a sudden cardiac arrest do not survive.
Yeah. Time is of the essence.
Time is that's why I call these one of my 3-minute medical emergencies, Jay. The AED needs to be on it. Like you said, CPR should be started within 15 seconds of this happening. And then that AED needs to be applied and turned on. It's going to say shock advised. Press the button.
Yeah. And if it does advise a shock, obviously you're going to do what it says. Press the button for the shock and, of course, stand clear of the patient. So you need to, before you push the button, you need to say, clear. And actually now in ACLS, I'm clear, you're clear, everybody's clear, just to make sure that nobody is touching the patient or the dental chair that the patient's in, because the electricity obviously can be conducted through the metal of the chair. So you fire the AED, and then you're going to resume CPR immediately as soon as the shock has been delivered. You're going to first check to make sure, see if they do have a pulse. And if they do have a pulse, then you're going to analyze it again to see if they if they need to be shocked again. But generally you're going to, even if they have a faint pulse, you're going to start chest compressions and ventilation to assist, because it may be a very weak pulse and it may not be a regular pulse. And so you're always going to, you always want to assess your ABCs at every interval, right? And if it's a non-shockable rhythm, you're going to continue with your CPR, continue with your BLS, and because you may circulate enough oxygen to the brain and the heart that the patient will go into a shockable rhythm, which is ventricular fibrillation. That's really the only shockable rhythm.
And note on the algorithm, Jay, immediate treatment improves chance of survival. I like for everybody to know, for every minute you do not shock this patient, they lose 10% survivability.
Yeah. Every minute. Exactly.
Every minute you're losing 10%. And Jay, I mean, it was over a month ago that sudden cardiac arrest got brought to the forefront in America when Damar Hamlin went down at the Monday Night Football game.
Yeah.
And it's impressive, the emergency action plan that the NFL does before every game at every stadium. They know exactly, they have their own airway doctors. They've got a medical team ready to go. They know the route of the ambulance. But I'm here to tell our colleagues, it's no different than our office too.
Right.
You've got to have that emergency response plan ready to go in your office. Everybody's got to know their role, because like Jay and I will continue to talk, there are a lot of medical emergencies that could occur in your office, but this one right here, you don't have much time, people. You've got to act. This patient wants to be able to go home again. All right. And thanks to the great work of all those EMS and the doctors, Damar Hamlin got to live to see another day.
Yeah. Exactly, because they had
Because
their
I mean,
plan.
they
had their plan in effect. They
yes,
rehearsed it, and they went right to it. Did
and
everything following the protocol.
that's right. And they did CPR correctly,
Mm-hmm.
Jay.
Yeah.
All right. I mean, we're talking about depth of compressions and everything. All right. Because that's critical. You've got to be able to force that blood, like we said, so we can prevent a brain or cardiac injury from occurring right there.
1.5 to 2 inches of depression in an adult.
So, and again, I want everybody to understand a sudden cardiac arrest is not a heart attack, because with a heart attack, the patient is still awake and their heart is beating.
Yeah.
All right. With SCA, that's not happening.
Yeah. I mean, if you don't act fast enough with a myocardial infarction, they could end up in VFib and sudden cardiac arrest. So you've got to, obviously you have to work quickly with that too, to try to relieve some of their symptoms. And of course, get them on oxygen, call 911 right away, so that paramedics get there as soon as possible. Now, if you are able to start an IV, it's a good idea to get an IV in the patient, even if you don't, if you're not ACLS certified. So you can at least get saline in the patient system. So when the EMS shows up, they can give their ACLS drugs and ACLS protocol right away.
Right. But if you've never done that, continue your chest compressions.
Just only do what you know how to do.
Correct.
And that goes for, in your office or anywhere. The Good Samaritan law will cover you as long as you do what is within your scope of training, and that you do it as correctly as you can. Obviously, there's no gross negligence.
That's correct. And so when you go back to your office after watching today's PharmaDocs, make a note, not a mental note, write it down so that you follow through with this. Number one, where's the location of my AED? Mm-hmm. Number two, check my batteries, make sure they're in date. Number three, check my pads to make sure they're in the date. If I treat children, do I have pediatric pads and are they in date?
Yeah.
Does my staff know how to fully use the AED?
Yeah, everybody should be able to apply the AED.
It's all about teamwork.
Yeah,
it's all. And what's so sad, Jay, is that not all of our states mandate an AED.
Really?
Yes.
Oh, I thought they all did.
No.
Oh,
so
well,
if I'm a dentist in one of those states that does not, I will be.
I'm going to have one.
AED. Yes,
I'm going to have one. Exactly. All right. So,
and Jay, I always like to read the disclaimer. This chart is to be used as a guideline. It does not guarantee to prevent an unfavorable outcome, result, or death. Practitioner may choose to deviate from the algorithms based on their clinical experience, training, and factors unique to that individual.
Yeah.
So bottom line out there, every one of you that listen to us, you need to have regular medical emergency preparedness on an annual basis, not an occasional basis.
Yeah, exactly. You
got to be able to prove this, Jay, if you have a negative outcome.
Yeah.
All right. Because Jay, are you going to want them to say, Dr. Reznick, when was the last time you took a medical emergency lecture? Yeah. Oh, 20 years ago.
Yeah.
Really? Are you prepared, sir?
Okay. Yeah. So what I learned in my very first ACLS class when I was a surgery resident is the ACLS guidelines. These guidelines we're showing you are a cookbook, but you need to be a thinking chef.
Yes.
Right. All right. Okay. So let's go to our next slide, where we're going to talk about, I think we mentioned it before, PharmaDENT. And John, what is PharmaDENT?
Jay, PharmaDENT is a right now 15 modular program that's going to thoroughly educate and update all dental healthcare professionals. It's going to come right to you in your lap with a laptop or a desktop. It's going to come to you in your office. And we're so excited about this. It's about to be released very soon.
Yeah. And within the next month or two, hopefully.
Yeah. Yeah. And looking at the modules right now, it's exciting because, look how many drugs we're talking about every month, Jay. And I mean, you said it best. If you've been out for 5 years, there's 500 new drugs. And I'm sorry, we've got medically compromised patients. We got medically fragile patients in our office. You've got to be able to prevent an adverse drug reaction.
Yep.
And
Absolutely.
PharmaDENT is going to help you because what kind of pharmacological training did you get in dental school? Do you remember much? Okay.
No.
Yeah. All right. And so, and Jay, the other thing, you might be lucky to find a lecture somewhere, and that lecturer might be talking on one topic, but I'm here to tell you by the end of the day, you're scratching your head. Hey, what all did he or she talk about?
Yeah.
All right. Well, guess what? With PharmaDENT, it's web-based, Jay. So you can go to it anytime, all the time, any place.
As often as you want. Yeah. From wherever you're, from your phone, from your laptop, from your desktop.
So we can just go right down the list.
On a plane, on a train, in a boat.
Yeah. As long as you got good internet, that's all that matters. Okay. And you got hypertensive medications, CHF, blood thinner, antiarrhythmic, cholesterol lowering drugs, diabetic medications.
And that's just in the first 6 modules. We got 15 of them.
To everybody in the PharmaDocs Nation, Jay and I are already talking about other modules that are coming out after this as well too. So you're going to stay updated on this information, no doubt.
Yeah, it'll be updated all the time.
But you know, Jay, with the big push right now with opioids and all that, there's a section right there, our module number 10, analgesic and opioids. Yeah. We're going to have a section on emergency medications and preparedness. Yeah. When was the last time you had a great lecture or anything on emergency medications? Okay.
Yeah. Mm-hmm.
There it is right there. We'll talk about the top 200 prescribed drugs, bisphosphonates. And then I love the last 2 drugs. Jay, drug-to-drug interactions, as well as I write this drug, but my patient's on that drug. What do I have to worry about?
Yeah. Again, drug interactions. Yeah. All right. So, go
ahead and list them out, Jay. There you go. All you.
Okay. So, I mean, obviously there are advantages. You don't have to travel. You can do it from the comfort of your home or office. You don't have to stay anywhere. You don't have to get meals out. And again, you can review this material as often as you want. So that makes getting the CE very easy.
Yes.
All right. So it's going to be on dentallearning.net, which is a educational website that's been around for quite a while. I think they have 70,000 dentists who are in there subscribed. Yeah. Yes. So that's where you'll find. We'll of course talk about it again as we get closer.
Jay, one other thing I want to mention about PharmaDENT, something else that the subscribers will get that you will get nowhere else. At the end of each month, you'll get what's called the new medication alert for dentistry, Jay. Mm-hmm. And all of the drugs that we've talked about, there'll be specific questions that you should ask your patients. Like if they're diabetics, what are some of the questions you should ask? Or if they're on an HIV medication, what are some of the questions? It's just another guide for you to use when you walk in to do your interview with that patient and their health history as well too.
Exactly. So our next PharmaDocs is going to be on Pharma Friday, the second Friday of each month, March 10th. And so we'll talk about the drugs that were approved in February, so this month, and a new medical emergency. So we hope that you can join us for that.
Yes, please do.
We'll see you next. And of course, if you miss our live broadcast, then you can also watch on YouTube and on Facebook and on LinkedIn. So that's where we're live streaming too. So we will see you next month.
Thank you.